Good afternoon, everyone. My name is Mina Nabavi, and I'm a program manager with the University of Alabama at Birmingham School of Public Health's Office of Public Health Practice. I'm excited to welcome you to today's webinar, Responding to the 2022 Monkeypox Outbreak with Dr. Nicolas Van Wagoner. This webinar is made possible by the Alabama Regional Center for Infection Prevention and Control, Training and Technical Assistance, or ARC-IPC. As a reminder, this is a 90-minute webinar to allow Dr. Van Wagoner to share his expertise around the monkeypox outbreak and to answer as many of your questions as time allows. The ARC-IPC was established to meet the consultation and support service needs surrounding infection prevention and control throughout the state of Alabama. The center is a collaborative effort of the Alabama Department of Public Health's Infectious Disease and Outbreaks Division and the University of Alabama at Birmingham. The ARC-IPC provides training and technical assistance to infection prevention and control and public health professionals in areas needed to detect, respond to, control, and prevent infectious disease outbreaks. You can learn more about the center, view and listen to past trainings, webinars, and podcasts, request training or technical assistance, and view infection prevention and control resources at our website, uab.edu/ARC-IPC. You can also email arcipc@uab.edu with any questions and stay up to date about future trainings by signing up for our newsletter on the homepage of our website. We would like to thank our co-sponsors for today's webinar, the Deep South Center for Occupational Health and Safety and the Region 4 Public Health Training Center. You can learn more about their programs and the centers as a whole at their websites listed on this screen. We'd also like to let you know about our next upcoming webinar with Dr. Stella Aslebekian on the mystery and epidemiology of long COVID. 2.5 years into the COVID-19 pandemic, there is emerging evidence that in some patients, its symptoms may linger for months or even years after the initial infection. While prevalence estimates vary widely, such long COVID symptoms likely persist in more than 10% of all COVID-19 cases. This webinar will summarize the current scientific debate about long COVID. Is it an autoimmune disease, a consequence of comorbidities, or something else? This webinar will be held on September 29th at 12 p.m. Central Standard Time, so please be sure to register at the link on this page. Continuing education credits have been approved for nurses by the Deep South Center for Occupational Health and Safety for this program. In order to receive credit for this training, you must register for the training, watch the entire program, and complete the evaluation following the program. Upon completion of the evaluation, you will be directed to the Alabama Nursing CEU request form, which you will also need to complete. CEUs will be awarded by the Deep South Center for Occupational Health and Safety. You do not have to submit directly to the Alabama Board of Nursing. CE units for this program will expire on September 15th, 2023. If you experience any issues, please email us, arcipc@uab.edu. And now it is my pleasure to introduce our speaker. Dr. Nicolas Van Wagoner is a Utah native and earned his undergraduate degree from Weber State University in Ogden, Utah, before coming to UAB to earn his doctorate in cell biology. He also completed his medical training, including medical school, residency, and fellowship at the UAB School of Medicine before joining the faculty as an assistant professor for medicine in the Division of Infectious Diseases in 2011. He has served most recently as the assistant dean for students and as an associate professor in the Department of Medicine and Division of Infectious Diseases. In addition to his role as an instructor and leader in medical student services, Dr. Van Wagoner has a passion for research. He studies sexually transmitted infections and HIV in at-risk populations with a focus on how societal variables influence a person's chance of infection. Additionally, he currently serves on several national councils and committees focused on infectious diseases research and treatment. So welcome, Dr. Van Wagoner. Thank you so much for being here.
Thank you so much for the opportunity to be here today and to ARC-IPC, not only for the opportunity today, but for the incredible work that you do in training and technical assistance. Today, I guess I should share my disclosures before we get started. I serve as a co-medical director and the PI for the Southeast STI HIV Prevention Training Center. This is a group that is tasked with providing educational resources to healthcare providers in best practices related to STI management and HIV prevention. And I also serve as the co-primary investigator along with Dr. Gerd Burkholder for the Alabama AIDS Education Training Center. The other thing I will mention to you is that at certain points in our conversation today, I will share some clinical images with you, and I'll let you know when I am about to share them so that you are aware of that. So the main objectives today are two for our discussion, and my hope is that by the end of our time together, that you will have knowledge and about the history of monkeypox prior to the current outbreak, and then be able to detail the current public health responses to monkeypox in the United States. Much has happened over the last couple of months, and I'm excited to be able to share with you much of the incredible work that has been done. So if we break down what we will talk about today, there are really four parts. The first is really the virus and its history. We'll talk a little bit about areas where it is endemic, as well as the current outbreak. We'll talk about transmission. We'll talk some about clinical manifestations, and we'll talk about that in the context of classic monkeypox, kind of what we have seen previous to this outbreak and some of the differences that we've observed in this particular outbreak. And then we'll spend a large amount of our time talking about the response to monkeypox in four main areas. Diagnosis. How do we diagnose it, and how has that process evolved? Treatment. What is available? And there is a little bit, it's quite limited, but I will share with you a little bit about the data related to treatment. Prevention. Specifically, we'll speak about vaccination, as well as some of the efforts that our partners in the monkeypox outbreak have taken to reduce potential for infection. And I think the place to really end, and really an important area, is the prevention and addressing stigma related to an infection as we've seen in this current outbreak. So let's talk about the virus and its history. So just a few words. It is a virus that is double-stranded DNA virus, and this is a group of viruses, or monkeypox belongs to a group of viruses that infect all sorts of animals. As you can see, birds, reptiles, insects, mammals, we see it. And in fact, there are 11 pox species or viruses that can cause human disease. Now, most of these are zoonotic or are found in animals and can be transmitted to humans through contact with animals, similar to what we see with monkeypox. There are really actually only two viruses in this family that are exclusive to humans: the variola virus, which causes smallpox, and molluscum contagiosum, which causes skin manifestations and is typically self-limited or a short-lived minor type of infection. Monkeypox was first discovered in 1958, and this is where it derives its name. It was actually found as an outbreak in monkeys that were being kept for research. And that name has stuck. The first human case was reported in 1970, and we still don't exactly know the source of the virus. We know it's found in African rodents and non-human primates, and they may be the harbingers for infection. But again, we don't know sort of its animal reservoir at this point. Now, monkeypox is endemic in certain parts of Africa, specifically the tropical rainforest regions of Central and West Africa. And I've listed here the countries where it's been found. And this particular image is just showing you over time where cases of monkeypox have been reported. And I will point out that the majority of cases, and where we do find it most, is in the Democratic Republic of Congo, as well as Nigeria. And so over time, we have had outbreaks. As I mentioned before, the first case was reported in 1970. And this is a graph showing you points at which there have been outbreaks. And you can see various outbreaks that have been endemic in endemic areas, as well as outbreaks that have been outside. And in those cases where outbreaks have been outside endemic areas, it's typically been or has been because someone has traveled or been in an endemic area and then traveled to another location. I'll point your attention to 2003 for just a second for a couple of reasons. One is that this particular outbreak had 47 cases. So, and at least in this time frame, excuse me, of 1970 to 2016 was the largest outbreak. And this actually occurred when domesticated prairie dogs were kept in close contact with animals from endemic regions of Africa. Those animals were infected and then infected humans. And again, there were 47 cases of that. This is really just to give you an idea of what we have experienced before this outbreak of monkeypox. So now turning to the 2022 outbreak, the first case was actually confirmed. It was thought that there was a case of monkeypox, and we occasionally get cases of monkeypox, again, outside of the endemic areas. But the first case was confirmed in the United Kingdom, and it was in a UK citizen who was returning from Nigeria. So it makes sense, sort of that typical pattern of somebody being in an endemic area and then traveling back to their either home or wherever they're visiting. But then about 6 days later, there were 2 new cases in the UK, and these individuals had no travel, and they had no link to the index case. About 6 days later, we saw cases in Portugal, Spain, the US, and Canada. And by June 5th, there were 920 confirmed cases, 70 suspected cases in over 30 countries. If we move forward now, and I will point your attention, this is an available on the web. You can sort of track and follow cases of monkeypox. And if you look at this at various dates along the way, you can see that there were 920 cases at the beginning of June. By June 21st, there were almost 3,000. I'll point your attention also to the August 26th and the September 13th date, not only because the large rise in cases, but if you look at the bottom of each of those panels, you will see the countries that were leading the number of cases. And while earlier on it was European countries, the United States now and continues to have the most cases of monkeypox in the world. Looking more specifically at the United States and looking back again to June 17th, the cases started to be reported in different states, and that is designated by the blue. By the 26th of July, almost all states had cases, and really by today or yesterday when I was able to upload update this information, every state in the US was reporting cases, some more than others. The darker the blue, the more cases that are reported, with a total of 22,774 cases. And in the state of Alabama, 90 cases have been reported. Looking now at the trends in diagnosis over time, and I'm hopeful that this is actually a positive trend and that perhaps we have seen the peak, what you will see over time, and this is demonstrating the number of cases diagnosed, that we are starting to see that arc down trend. So again, my hope is that this will continue. A word about individuals who are being diagnosed with monkeypox. We are observing that most cases are in men. Most, not all, but most cases. And most cases are reported in gay, bisexual, and other men who have sex with men. Now, if we look over time and we look at the proportion of individuals by race, ethnicity that are infected or have been diagnosed, what we see is that cases have shifted predominantly from non-Hispanic white men to near equitable distribution among Black, Latino, or Hispanic and non-Hispanic white men. And this increases the disparities among racial and ethnic minorities when we consider the proportion of the overall US population that makes up each of these groups. So in some ways, perhaps not an unexpected, but certainly a concerning trend that we are observing with monkeypox. Before we move forward, I do want to make a comment, and that is that pathogens don't care who we are. They really don't care about our race. They don't care about our birth country, our gender, or our sexual orientation. But rather, there are pathogen-specific, they're environmental, societal, and host factors that influence the probability or the likelihood of an individual or a group of individuals being infected. We are all, though, potentially, potentially susceptible to monkeypox. Let's turn our attention now for a few minutes and talk about transmission. Now, as I mentioned, monkeypox is a zoonotic infection. In other words, we know that it lives in animals, although we're not 100% sure what its reservoir is. What we do know in endemic areas that people come in contact with animals, whether that's a live animal or it's animal products, and that close contact can lead to transmission. Now, once a human is infected, it is possible for that individual to then transmit monkeypox to other individuals through close contact. The typical pattern that we have observed, and I've already mentioned, is that a person who has the infection can then travel to a non-endemic area and through close contact can then transmit the infection to other individuals. And so when we think about transmission, there are several different ways that we observe this, and specifically speaking, human-to-human transmission. We know that it can be transmitted in respiratory droplets, although this is a relatively rare transmission route in the 2022 outbreak. Skin lesions are infectious, and so close contact with those and body fluids can lead to transmission. We also know that surfaces, objects, and think about mostly things along the lines of bedding, towels, clothing, things that have been really against an individual's skin can transmit the virus. And so looking at the other side of this equation, then the virus can enter through the respiratory tract, through broken skin and through mucous membranes. Speaking a little bit more about intimate contact, and in particular what we are observing in this particular outbreak, we do see oral, anal, and vaginal sex or touching of the genitals or anus of a person with monkeypox as an important transmission route. And I will say that monkeypox is considered sexually transmissible. Now, the reason I use the term sexually transmissible and not sexually transmitted is because there are other modes by which monkeypox can be transmitted. Sex is one of those and is related to the intimate contact. Okay. Now, it has been observed that monkeypox in recent studies can be found, or DNA can be found in saliva, in semen, in other fluids, but we don't understand as well the impact of finding the virus in those secretions as an actual mode of transmission. We believe it to be more the intimate contact. So expanding beyond sex, certainly there are other activities where people come into contact with each other. And one that I want to point your attention to is normal activities of caregiving. If I have a child and I'm holding that child and I have monkeypox and caring for that child, I can transmit it to that individual or someone else that we are caring for. And again, I put here touching of fabric, shared surfaces, and objects used by a person with monkeypox are ways and modes of transmission. If we now transition for a moment to clinical manifestations, I'd like to talk with you about the arc of infection. What happens first is after a person comes into contact with monkeypox and they are infected, there's an incubation period, okay? And during that incubation period, they have no symptoms and they are not contagious. Now, in most cases, this incubation period is anywhere from about 1 week to 2 weeks, but there is some variation by individual. And 5 to 21 days is that period of time where incubation can occur. Now, if you look at guidance, and we'll talk about this later, of if somebody has been exposed, what is the period of quarantine? Well, 21 days to ensure that we are sort of meeting that potential spectrum, okay? After the incubation period, the individual has a prodrome. Now, I'll pause for a moment just to say that what I'm presenting to you right now is our understanding of classic monkeypox infection and its phases. I will come back and talk about some of the variations that we've observed in individuals during the 2022 outbreak. But again, after the incubation, there is a prodrome. And the prodrome typically lasts about 1 to 4 days. People have fevers, muscle aches, chills. Lymph node enlargement is a characteristic of this particular infection. They feel bad, kind of like they have the flu, okay? And then toward the end of this prodrome, they often will develop lesions in the mouth, eyes as well, so sort of the head, and at that point as well, they're viremic, or there is virus that is in the, can be detected in the blood. Now, after this prodrome, individuals develop a rash. The rash lasts anywhere from 2 to 4 weeks. As I mentioned, starts really on the face, mouth, and then spreads to the extremities. It can include the palms and soles. And so if we look again at those manifestations, this is just a representation of the prodrome and also the skin manifestations. I do want to focus, though, more on the evolution of skin manifestations. And what you're seeing here, again, I'll keep emphasizing this is classic monkeypox rash evolution, and you're seeing it on the background of different skin pigmentations. The way that it starts out is usually as a macule or an area of color change that after a couple of days it raises, okay, and is what we call a papule. And that can last typically from about 1 to 2 days. The papule then evolves into a vesicle or a blister, okay? And after that forms a pustule. The pustule lasts for a few days usually, and then eventually will crust over or scab over and heal. A couple of comments about these, and I may mention these a couple of times, but these are firm vesicles or deep-seated in the skin, okay? And they sort of take on this as they move and evolve, sort of this rubbery consistency, okay, as well. They are painful. And as they move toward that crusting or scabbing phase, they do become more itchy to the individual. Here are some examples. These are all taken from this current outbreak. And you can see them in different stages. In a classic monkeypox infection, what we typically observe is that all of the lesions or all of the rash is in a similar stage. So you see all of them as papules, or all of them as vesicles, all of them as scabs, etc. And so they're similar size and in the same stage. And individuals usually have anywhere from 10 to 150. Generally, they're painful, and as I said, itchy as they evolve. And there is virus in the skin lesions. Something to keep in mind is that the rash is infectious, and it's infectious from the time that symptoms start until the lesions scab and fall off and a new layer of skin is formed. An important piece of information to share with individuals who are living with monkeypox so that they are aware of that infectiousness and can take steps to prevent transmission to others. As well, us as potentially involved in healthcare, understanding the infectiousness as if we and when we see individuals with monkeypox. So after the rash, there is what we call the recovery phase. And really what I mean by this is that monkeypox is self-limited. And most individuals make a full recovery. In fact, greater than 99% of individuals make a full recovery, but complications can occur, and in particular in individuals who are immunocompromised. Now, I do want to mention that if you've seen information about monkeypox, you'll see that mortality rate is reported anywhere between 1 and 10%. So there are different clades, 2 different clades basically of this virus. One virus has a lower mortality rate, closer to 1. The other clade of the virus has a higher rate of mortality, around that 10%. We are fortunate in that the clade that we have observed causing this particular outbreak has the lower mortality rate. So again, in most individuals, is self-limited. Let's turn our attention, and I will have in the next couple of slides some examples, typical examples of what we're observing in the 2022 outbreak, and there will be some pictures of genitals, more genitals in those. We are seeing some differences in this outbreak. What we're noticing is that the prodrome is less prominent or even absent. So individuals are not having fevers, they're not having myalgias. Their first symptom may actually be a pustule, or a lesion associated with monkeypox. We are seeing genital, perigenital, and perianal lesions very commonly, and we're seeing individuals with fewer lesions. As I mentioned, that sort of 10 to 150 is typical. In some cases, we're seeing individuals with 1 or 2 or 3 lesions. Most cases, thank goodness, are mild. And I will point out that often the manifestations of monkeypox are mimicking other sexually transmitted infections. So herpes simplex virus, for example, syphilis, lymphogranuloma venereum, topics perhaps for another day, but for the individual who is seeing a patient with monkeypox, these are other things that you should consider. Or if you're considering those other things as the potential cause of a patient's symptoms, think about monkeypox as well. I will emphasize that we are seeing quite a bit of proctitis. So proctitis is inflammation of the end of the colon and is associated with rectal pain. It's associated, can be associated with a discharge as well. Very disturbing and unpleasant to the individual who is suffering from it. But again, a less typical presentation of classic monkeypox, but actually a quite common manifestation that we're observing in the 2022 outbreak. So to illustrate some of the points that I just made, I am going to share with you some images from a patient who's was discussed in the New England Journal of Medicine early in this outbreak. And so this is a 31-year-old male who actually presented with perianal and penile lesions, as well as rectal pain and rash. And so this patient actually, on day 1, the first time they presented to their healthcare provider, had noticed that they had some itchy white bumps on their anus, and went to their doctor. And they thought at that time that this could represent herpes, and so gave them therapy for herpes, but it didn't get any better. And in fact, after that time, the patient then developed painful proctitis and also developed some spots on the genitals. And pointing out here, if you can see my cursor, the sort of typical pustule, and a point I will make that I didn't make earlier is we often see umbilication, or sort of this indenting of the middle of the pustule, as you can see here. Now back to the case. The patient presented with rectal white spots, was treated for herpes, then developed penile spots and symptoms of proctitis, then developed some systemic symptoms, and also some pustules were identified on other places of the body. So as you can see on the shoulder as well as the hand. The figure 3 that I'm showing you is just a reminder that we do see proctitis in this. And what you're observing is looking at the mucosa of the rectum, some inflammation and some friability or fragility of the mucous membranes. So again, some of the manifestations or the manifestations that we are observing have been different in this particular outbreak. Now, we do have to consider that severe disease and complications can occur. Thank heavens we aren't seeing many of them, but they can occur. And we think about this in persons who are immunocompromised. So for example, persons living with HIV who are not on treatment for their HIV and have a low CD4 count, representing that their immune system is weakened. Pregnant people, extremes of age, meaning both older and younger individuals, as well as individuals who have other immunocompromising conditions, whether that's because of a transplant and we're giving immunosuppressive therapy to help that sustain that transplant, or cancer, or chemotherapy for cancers, or immunosuppressive therapy for other reasons. All right, so I've talked so far a little bit about the history of monkeypox. I've talked about some about its clinical manifestations as well. And now I want to focus a little bit on diagnosis as we start to think about the response to monkeypox, okay? So the first question is well, who should be tested? Who should be screened, tested for monkeypox? Certainly anyone who has a classic monkeypox rash should be, okay? But we also want to consider individuals who are presenting with rashes that could be monkeypox, plus some sort of contact with individuals with a similar looking rash, someone who's been diagnosed with monkeypox, people who are in a close or intimate social network with a social network that is experiencing monkeypox, individuals with recent travel, and anyone who has come into contact with animals that are potential reservoirs. Really, though, thinking about this particular outbreak, the top 3 are the most important as we think about individuals who should be tested. Now, early on in the response, this is what we did, okay? If we thought somebody had monkeypox, the CDC had recommended a 2-step process for diagnosis. Now, there are centers all over the country, 120 of them, that are called laboratory response networks, and they have the ability to do tests to tell us if someone is infected with an orthopox virus, okay? Now, remember what I said earlier, there are a bunch of these, 11 of these. These first tests were not specific to monkeypox. If someone tested positive for that orthopox virus, the second step was confirmatory testing that was sent to the CDC. Real-time PCR was done. This confirmed monkeypox. So that was the original strategy early on in this outbreak. But it became, and this is what was happening really in May and early June with the outbreak. But it became clear that increased capacity was needed, and that capacity was needed quickly. And so the CD shared its diagnostics with several different labs that I've listed here. And as you can see, over the month of July, they came online with the ability to perform monkeypox testing. And really during this period of time, and by the time that the last 2 groups came online, the testing capacity increased and is around 80,000 tests per week that can be performed. And really, by August, we were seeing individual institutions, other organizations, hospitals that were developing their own tests. And I put this here because by the 18th August, UAB Hospital Lab had a monkeypox test available, which is really extraordinary, and I think speaks to just the incredible work of so many scientists and laboratorians here and abroad. And similarly, in other hospital and healthcare systems, testing has become and is becoming more available. So this has been the response to testing, a rapid up titration of the ability to do testing, both through various companies and now and also at specific hospitals. The testing and diagnostic strategies are linked to reporting systems so that information is being shared with the appropriate entities, i.e. CDC, other organizations, to ensure that we are in real time following this outbreak. So that was just a few words about diagnosis. Let's talk about treatment, okay, and where we are with treatment. Most cases, as I've said, are mild and really require supportive care. So it is things like pain control. This can be quite painful for some individuals. As well, I have seen patients who have had manifestations. Remember, I mentioned sort of with classic monkeypox, you can see manifestations head and neck and in the mouth, a lot of difficulty swallowing. And so help there as well. But again, supportive care to help them through this as the infection resolves. I will reemphasize again that there are some groups that are higher risk, those at the extremes of age, and I will point out children under the age of 8, and those with weakened immune systems. And also I will mention that there is concern for people with atopic dermatitis and eczema are at increased risk of having a more severe disease. So something important to consider as we're working with other individuals and thinking about those who potentially carry potentially a higher burden with an infection. So what are the treatments so that we do have available for individuals who do need them? You know, well, we've got a couple of things available to us. The antivirals that are available are brincidofovir and tecovirimat. Really, it's tecovirimat, and I'll explain why in a second. There's vaccinia immune globulin that is available, which is antibodies from individuals who have received the vaccinia virus and can be given to an individual with monkeypox and is protective. And certainly vaccination for post-exposure contacts. There are two, we'll come back to this and talk about this in more detail. There is a live vaccine and also another live, but a non-replicating vaccine. That is important, and we will focus more on the second because that is safe to use in individuals who may have immune compromise. All right, so let's talk a little bit further about the treatment. So as I mentioned, there are two antivirals that are available, brincidofovir and tecovirimat. And these have been studied certainly in vitro and have been demonstrated to have activity against monkeypox. But what is our real life experience in humans? Well, this is a retrospective study. This was published in August, or actually in May, excuse me, May. And this was looking back at experiences with individuals in the UK who had come from endemic areas with monkeypox over a period of time between 2018 and 2021. And really the goal of this was to look at it, to see, basically to look at adverse events related to these medications as well as viral dynamics. In other words, did they have any association with reduced virus, et cetera, things like that. The inclusion criteria for this particular study were persons diagnosed with monkeypox, and they, of course, either receiving one of these two medications. So this study has 7 people who participated. So again, acknowledging the limited information that we have at this time. Now, 3 of the individuals in this retrospective study have been treated with brincidofovir. And All of them developed elevated liver enzymes or liver inflammation, and all had to stop therapy. Okay, so even though it has been used in monkeypox, it really is not an agent that we are using, and really it falls on tecovirimat. Now, in this particular study, there was one person that was treated with this, okay? They received 600 milligrams twice daily for 2 weeks. They had no adverse event, and there was a shorter duration of viral shedding and illness in this individual compared to others that were included in this study. So a study with an N of 1 on this particular drug. If we look more recently, there has been another study. This was published not too long ago in one of JAMA's publications. And this was looking at compassionate use of tecovirimat for the treatment of monkeypox infection. And what they were assessing was adverse events as well as clinical resolution of the systemic symptoms as well as lesions in patients with monkeypox treated with tecovirimat. This study was included patients between June 3rd and August 13th. Importantly, this is a non-controlled study. And the individuals that were included were people with monkeypox. They had disseminated disease or lesions in some sensitive areas, such as the face or genitals. And these individuals took the oral tecovirimat formulation for 14 days. They did have the ability to extend it to 21 days if they needed to. And I believe one patient was extended to 21 days. So who was in this study? Well, there were 25 participants included. All were self-reported male. Their age was around 41 years, median age, I should say. 9 were living with HIV. There was one individual who'd had vaccinia virus a long time ago, and 4 had received 1 dose of Jynneos vaccine after symptom onset as a part of sort of that post-exposure prophylaxis response. If we look at their symptoms, really the majority of individuals were coming back to some of the ways we're seeing this particular outbreak manifest. 92% had genital or perianal lesions, okay? And fewer than 10 lesions was observed in half of that population. Now, a large proportion, 76%, had fever, so relatively common. And then you can see that other individuals had a smattering of symptoms, but really it was genital perianal lesions and fever were the most common symptoms reported. Now, if we look at the results, what they observed was there was complete resolution of lesions by day 7, okay, of therapy in 40% of patients. And by day 21, there was 92% resolution. Again, no control group for us to be able to compare to in this particular study. It was well tolerated. No one discontinued the therapy, but adverse events were reported. But it's hard to know if these adverse events were related to the medication or if they were related to monkeypox, because if you look at them, and if we go back, you can see that there is quite a bit of overlap between the symptoms that they were reporting. But again, it does appear to be safe and potentially helpful, okay? And their conclusions were that, again, it was tolerated well, but again, without a control group, there's really no ability to assess its benefit. More recently, as I was reviewing updated information this morning to see if anything had else had come out, there is a study, a case report of monkeypox virus associated severe proctitis that was treated with oral tecovirimat, 2 cases, okay? So again, a small case series. But what they observed was that patients reported rapid alleviation of the rectal pain associated with monkeypox after starting this particular therapy. So potentially benefit, time will tell as far as how much benefit is coming from this particular therapy. So let's move on then to vaccination for a few minutes. Vaccination does work for orthopox viruses. When we think about smallpox and what we use to vaccinate against smallpox, we don't use smallpox. We use another orthopox virus to vaccinate, and there is good cross protection. Now, there's not a monkeypox specific vaccine, but we do know that vaccinia virus protects against monkeypox, and there are two of these. There is the, and I don't know if I'm pronouncing this correctly, ACAM 2000, that's just what I'm going to go with, a live replication competent vaccinia virus, and then there's Jynneos, which is a non-replicating modified viral vaccine. And both are approved for individuals who are 18 years and older. So the response from the government, the CDC, Health and Human Services has been to get vaccination out to individuals who need it as quickly as possible. And this has been done in several phases. So phase one, which was really in June, was to use currently available vaccine stocks. And they were to be used for people with close contact with people known to have monkeypox, okay, which is something that we would consider post-exposure prophylaxis. In other words, I've come into contact with somebody with monkeypox, I could have it, I'm going to get that post-exposure prophylaxis because of that factor. The goal was also, and continues to be, to get the vaccine into individuals who have exposures in venues or areas where monkeypox is actively spreading, okay? So most of this strategy is around PEP, people who have come into contact with it and are very, very highly likely of coming into contact with monkeypox. Phase two, as we move a little bit further along, was to distribute more vaccine doses and really to not only do PEP, okay, but also to do PEP plus. And I put the definitions of what these are at the bottom of this slide. But this is the idea. PEP plus is the idea of emphasizing a vaccination of persons at high risk of exposure, but in the absence of a known exposure, okay? So trying to get the vaccine to individuals who have high risk, but again, not a known exposure. And as we move forward and as more of the vaccine becomes available, the goal is to more broadly implement both PEP and PEP plus. Let's talk for a moment about Jynneos vaccination. Okay, 2019 is when it was approved. It is approved for the protection of smallpox and monkeypox for individuals 18 years of older, and we talked a little bit about indication, but really the effectiveness is not known at this point. It is considered a 2-dose series, 4 weeks apart, and it is safe in persons with immunocompromising conditions. Now, the way it was studied and the way it was approved by the FDA for delivery is as a subcutaneous injection, okay? And the reason that I put this up here is because the way that we are delivering it now has evolved, or the new recommendation has been to do it intradermally, okay? Where did that come from and how did it happen? Well, there was a study that was done a few years back, in fact, in 2015, and they compared subcutaneous versus intradermal injection of this particular vaccine. And what they reported in that particular study was that whether it was subcutaneous or intradermal, that both provided a similar immune stimulation, and so activated a similar immune response in the ways that they were measuring it. The important factor in particular for this outbreak is that intradermal injection requires 1/5 of the dose. So if you give it subcutaneously, you can only give that dose to one individual. But if you give it intradermally, you can give it to 5 individuals, or that one dose will benefit potentially 5 people. So in the desire to get this to as many individuals as possible, this decision was made. And again, I'll come back to that in just a moment. Now, there were some side effects. There was more redness, firmness, itching, and swelling at the injection site, but there was less pain associated with intradermal injection. And so the FDA on August 9th gave this declarations that circumstances exist justifying the emergency use of vaccines. The FDA may issue an EUA to, or an emergency use to allow unapproved vaccines or unapproved uses of approved vaccine. And so basically what they were saying is we can give this intradermally and as an unapproved use of an approved vaccine, okay? So who should be vaccinated? Well, people who know that they've had a sex partner in the past 14 days who has been diagnosed with monkeypox, and people who have had multiple sex partners in the past 14 days in a jurisdiction with known monkeypox, which is kind of pretty much everywhere at this point. So known contacts and a little bit more information, gay, bisexual, and other men who have sex with men, as well as transgender people who report in the past 14 days, group sex or sex with more than one partner, as well as sex in commercial sex venues, events, etc. Now, this came out and was reported actually in the last day or so, and is a study published through the MMWR. And basically what they have observed that in the US is that HIV or a recent sexually transmitted infection are very common among individuals with monkeypox. In fact, 38% of people with monkeypox had HIV, 41% have had an STI in the last year, and together 61% had either HIV or an STI. So when we think about individuals who will really benefit from vaccination, we want to prioritize people with HIV and STIs, or for monkeypox vaccination. And we want to offer also, on the converse, HIV and STI screening for people evaluated for monkeypox. So where are we in these distribution efforts? Well, the goal has been to provide equitable allocations of this vaccine that's based upon current case proportion in different parts of the country, as well as populations at risk for severe disease. And as of September 9th, which is the last update of information or the last time this was updated, almost 800,000 vials of Jynneos vaccine had been distributed. And HHS anticipates another 1.9 million vials available in the rest of this year, and then 2.2 vials available in the first half of 2023. As well, this came out from the White House on August 30th, that the White House response team was announcing plans to support large queer events and equity interventions to reach communities at highest risk for contracting the virus. What does this look like? Well, basically, they have done and worked to provide vaccination at large events where attendees are primarily gay, bisexual, and other men who have sex with men. And here are 3 events that have occurred over the last few weeks where vaccination has occurred and been available at those events. The other piece to the White House's response is reaching population with barriers to care, and really figuring out ways to provide vaccination for individuals who lack access to care, including online appointment scheduling, and also to address the stigma that can be associated with attending public vaccine events that require disclosure of sexual identity, gender, or level of sexual activity. Certainly one of the concerns of the queer community, understandably so, is that coming in and having that there has been a sense of labeling associated with those who would really benefit from this. And it is hard to come forward anticipating stigma, whether perceived or real. If we look a little closer to home, the Jefferson County Department of Health and the work there has been really extraordinary under the leadership of Wes Williford. Monkeypox vaccine is available, and this information is available on their website. I will as well available on their website. The groups that are eligible for the vaccine are listed here. And so similar to what I've already mentioned, someone who's come into contact with someone in the last 14 days, another group, individuals who work in laboratory settings or deal with monkeypox specimen samples. Again, persons who are gay, bisexual, trans, gender nonconforming, gender non-binary, or other males who have male-to-male contact, and persons who work in are sex workers. So we've talked a little bit over the last few minutes, or last 15, 20 minutes, about the response to monkeypox. A couple of words, final words about that, and that is that ongoing surveillance and assessment of treatment and prevention strategies is going to be very informative. You know, we are, through emergency use, we are providing the best care and the best evidence-based care that we have available, but that is somewhat limited. And so more to come. Expect change, expect updates, and monitor the CDC monkeypox site closely for those updates. The site has been super helpful, not only for healthcare providers, but also for others who are interested and patients as well. So I'd like to end with this particular topic, and I will be done in, I promise, in about 3 or 4 minutes. Thanks for sticking with me on this. I'd like to talk about preventing stigma. And when we think about stigma, and we think about illness in queer people, we really acknowledge that that stigma has a huge impact on health. And I've modified this from a UN diagram on stigma. But basically, we know that stigma has a lot of influences on us, negative influences, whether that's direct harassment and abuse, discrimination, which includes access to healthcare and even violence in some situations. We know that stigma leads to marginalization, and that marginalization is associated with poor social and emotional well-being. And it also puts us in situations where we have increased vulnerability. And all of this impacts our health, whether that's through poor health services, access to health services, and even uptake. We also know that it influences poverty, mental illness, as well as physical illness. And I think that the concern and what we have the opportunity to work to prevent is that monkeypox leads to prevent the stigma associated with monkeypox. And so how do we do that? Because I do believe that we each can and we each play a part in doing this. And so the first piece is to use a health equity lens to be inclusive, to avoid bias and stigmatization, and in order to effectively reach our patients. So what does this mean? Well, we need to consider the longstanding systemic, social, and health inequities that have put some populations or groups at increased risk of illness, of poor health, of worse outcomes. And so in this particular context, thinking about the queer community, and in particular, gay, bisexual, and other men who have sex with men. We also need to think about the fact that our policies, our practices, our programs really need to recognize and reflect the diversity of the communities that we're trying to reach. So using accessible language and even tailoring our interventions and communications based upon the unique circumstances of individuals. I think that an example of the White House's response to attempt to do this has to provide access at events where gay, bisexual, and other men who have sex with men have gathered. And finally, to realize that health equity really is intersectional, that individuals belong to more than one group, and that there can be overlapping health and social inequities, but on the other side of that, that there can be actually overlying strengths and assets. And so leveraging those strengths and assets for communities is a way to address this. Whatever that disease process is. And so how do we do work to prevent stigma? Well, one of the pieces is to describe this as a legitimate public health issue that's relevant to all of us. This is not, even though we understand that in this particular outbreak, we are seeing it among gay, bisexual, and other sex who have sex with men, but we are all susceptible to monkeypox, and it is all of our need to address. We want to make sure that when we're communicating that we're using factual information, okay? And I won't go through each of these. We've talked about these, and hopefully the information that I provided today has been helpful in providing that factual information about monkeypox. And if we don't know the answer, we find the answer. We also need to think about how we frame monkeypox. So as we're talking with others about this, it's not a matter of saying you or yours. It's a matter of saying us or we. We as a community, or we as a healthcare system, or we as humans are working to address the monkeypox challenges or outbreak. It's our problem, not your problem. We also want to be careful and not use sensationalistic language or images. We need to show the reality of monkeypox, but not go to the extremes. We also want to make sure that we're using language that really does resonate with our audience, and use concepts that our audiences will find impactful. As well, we want to empower. We want to think about how we are moving forward with treatments and how we're addressing the monkeypox outbreak to minimize fear and really to promote action and a sense of personal agency. I do want to say that there is good evidence that there has been a proactive approach from the gay, bisexual, and other men who have sex with men, this community of individuals, and that data is telling us that informed decisions are being made to reduce chances of getting monkeypox, and that this will potentially reduce the spread of monkeypox. And with that, I do believe that the last piece that I want to say is working together. Working together, for my example as a healthcare provider, understanding the impact and value of community partnerships and alignment in order to address this outbreak. And I do think that we have made incredible progress thanks to the work of so many and many of you. So I will stop there. I hope that we've accomplished our goals of describing the history of monkeypox prior to the current outbreak and detailed the current public health response to it. A final word is we're up to the challenge, and I think that we're showing that as a community and group. And I want to thank everyone who has worked in health and the well-being of others, whether that's monkeypox or otherwise. It's noble work, and I am grateful for the contributions that everyone has made. And with that, I'm going to stop, and I'm happy if there are any questions to do my best to address it. I will also say that we'll keep the chat open. I suspect that there are experts joining us today who have important comments to make, and so please feel free to type into the chat if you have any comments that you would like to make.
Thank you, Dr. Van Wagoner. You have lots of thank yous and comments from colleagues all across the region. So we do have a couple of questions, and I would encourage those of you listening to submit your questions through the Q&A box, and we'll get to those. So the first question came earlier on in your presentation. I know you mentioned that, in this current outbreak, the prodrome phase is less prominent or has even been absent in some cases, but are individuals contagious during that phase?
That's a great question. So the individuals are not contagious during the incubation period, but there is a potential for individuals toward the end of the, or to be contagious during that incubation period. Now, we understand that less well than we understand the infectious stage of the lesions. But as I mentioned, it can be spread through respiratory droplets. And so there is potential for people to be infectious during that period of time.
We're going to switch gears to when you talked about the vaccination. So someone asked a question, as more vaccines become available through the end of the year and next year, do you think that full doses of vaccine will be administered rather than the 1/5 dose?
That's a really good question. And I don't completely know the answer to that yet. You know, the FDA approved full dose is that subcutaneous dose. You know, the data from studies suggest that 1/5 of the dose is as effective at stimulating an immune response. But how that actually translates to full protection is still to be, I think, understood in better terms. And so coming back to that, what I would say is I think it's going to depend upon the data and what we see moving forward. I think if we do see that from a protection standpoint, that 1/5 the dose is just as effective, then probably not. We'll just continue with that 1/5 of the dose. Now, that's for the emergency use portion. I am not an FDA expert. I don't know all of the steps of getting approval for something along those lines. And so that I'm sure will play a role as well there. But my hope is that we'll make the decision to base it upon the data and what we're seeing as most protective there. That's a really good question.
Another question is specific to Alabama. Have Alabama's numbers gone down now that there is a vaccine available? And if not, why?
You know, that's a great question. And if somebody is on the line who knows more, I have not actually seen the ARCs specific for the state of Alabama to be able to see where we are with that. My expectation is, and again, please understand that this is not fact-based, this is sort of a theory, is that, you know, if we look where monkeypox first showed up in the United States, and we follow that as it's traveled to new states, each state has that rise, and then we'll have that fall. And I think that we are behind in some ways other states that have been experiencing monkeypox for a longer period of time. And so I do think that the response in the state has been robust. Where we are, though, in particular right now, I apologize, but I'm not able to speak to the specific numbers of where we are. One of the things that I think we have to consider is another piece that I mentioned earlier on, and that is that we're seeing monkeypox in terms of a health disparity as we're seeing it move in from non-Hispanic white men to more diverse populations. And so the one thing I think we have to be really diligent about from a policy, from a public health standpoint, from a health provider standpoint, is the idea of is the vaccine getting to the individuals who will benefit most from that? And I do, I think it needs to be a focus to ensure that that disparity does not continue, because I think the potential is there. So again, happy to see the White House, others putting strategies together to reach individuals who find it difficult. I mean, I think it would be quite difficult, you know, the worry about maybe I'm not out, or and this experience could out me to a community, my cis community. And so figuring that piece out, I think, is going to be important as well. Wow, I totally got off on a tangent there. I'm sorry about that. Coming back, I think that I'm hopeful that we will soon be on the downslope, and believe that we will be, but I'm not 100% sure where we are. Is there anybody else on who has some of that information, perhaps?
If someone is, please feel free to write it in the chat or submit through the Q&A box, and we'll be happy to share that with everyone. Another question, is there any evidence of human to pet transmission of monkeypox? Have we seen that? We have.
We have seen, there was an article in Lancet a little while ago about transmission to dogs. And so one of the pieces of information that we share with individuals who have concern for monkeypox or have monkeypox is that isolation from animals is important as well. As I mentioned before, we know it's endemic in animals. It's in animals. And what we want to prevent as well is it becoming endemic in this country in animals. And so, yes, there have been reports, and really important to share that piece with individuals who are infected as well to prevent that transmission.
So isolation from people in your household, including your pets. That's a great message.
Including your pets. Yeah, it's a great point and an important one. So thank you for that question.
Sure. If anyone has any other questions, please feel free to drop them in the Q&A box. I have one question, kind of predictions for the future. Do you think we'll keep seeing this current outbreak increase, or do you think it's leveled off and starting to decline?
Time will tell. I'm hopeful, just basically looking at the curve of new diagnoses, that and the aggressive vaccination efforts, that we are hopefully trending downward. Now, as far as that tail of still having cases and getting to zero, I don't know how long that will take, and I think that this is something that we need to be vigilant about and continue to address into the future, because but I do think we are on the right track, and I'm hopeful that we will see. I think we are seeing some resolution or a downward trend as a nation. But again, I think it's going to take us a while to completely eradicate this.
Sounds good. Well, I don't see any other questions in the chat box. You've got lots of thank yous. Several colleagues, it looks like, who know you are saying hello. So I just want to thank you again, Dr. Van Wagoner, for this very timely webinar and for staying on a little bit longer to answer our questions. I want to thank everyone who has joined us today, and we hope to see you all back at our next seminar on Thursday, September 29th on Long COVID. We're going to give you a few extra minutes back of your day. So thank you again.
Thanks, everyone. I really appreciate the opportunity to be with you, and thank you, Mina. Take care.
Thank you. Have a wonderful day.